the Institution of Engineers Singapore Biomedical Engineering Technical Committee Joint Seminar on Healthcare Engineering. My name is Siu Lok To, and I shall be your moderator for the first part of today's seminar. I'm very pleased to note that this seminar has attracted over 210 registrants, not only locally in Singapore, but also from other countries like Australia, China, Japan, Myanmar, the US, just to name a few. I have also been informed that the Chinese Medical Device Journal is also streaming this Zoom session on their own platform so as to reach out to the Chinese clinical engineers too. Okay, to begin, let me introduce our first speaker, Mr. Takahiro Hirayama, a certified clinical engineer from the Clinical Engineering Center of Okayama University Hospital, Japan. You already have the info about Mr. Hirayama, so I will not read out his biodata here. The title of Mr. Hirayama's talk is Diverse Roles of Clinical Engineers in Japan. Mr. Hirayama, so over to you.
Okay. Good morning, everyone. I'm Takahiro Hirayama. I'm working as a clinical engineer at Okayama University Hospital. I'm pleased to have this valuable opportunity to present here today. Today, I'm going to talk about diverse roles of clinical engineers in Japan. Here's today's outline. First of all, I'd like to talk about the development of clinical engineering in Japan. After that, I'd like to talk about my work at Okayama University Hospital and other activities related to clinical engineering. Lastly, I'll talk about the current COVID-19 measures in Japan. The history of clinical engineering in Japan started when the Clinical Engineers Act was instituted in 1987 due to the increasing sophistication and specialization of medical care. So there are currently more than 45,000 qualified clinical engineers, and their main duties include the maintenance of medical equipment and the operation of life support equipment in the clinical field. This slide is about characteristics of CE in Japan and overseas. In the US and Europe, there are separate qualifications for operation of ventilator, cardiopulmonary bypass, hemodialysis, and healthcare technology management. On the other hand, a Japanese CE can do all the work with a single national license. Japanese clinical engineers acquire knowledge not only on engineering, but also on medical science in the course of education. They are also trained in the operation of life support systems, so they can provide clinical skills in the medical site. Traditionally, Japanese CEs have focused on hemodialysis, HTM, CPB, and ventilator. However, in recent years, the number of roles for clinical engineers have been increasing due to the diversification of work. I'd like to introduce some of them. In the operating room, as shown pictures, the equipment used in surgery has become more complex due to the development of technology. And by understanding the principle and operations of each equipment, we provide support for robotic surgeries, navigation systems, endoscopic equipment, and others. In the catheter room, as shown pictures, we are involved in a wide range of cardiac procedures, such as polygraph, IVAS, ECMO, IABP, pacemaker management, arrhythmia treatment, and TAVR. So, a clinical engineer is indispensable. Hyperbaric oxygen therapy is an effective treatment for the disease shown in the slide. CEs manage and operate the equipment. In recent years, the overwork of doctors has become a problem in Japan, and task shifting and sharing from doctors to other medical staff will be critical. One of them is endoscopic work. These duties are expected to shift to CEs in the future. However, the law is yet to be developed. So far, I've talked about the duties of CE in clinical settings. As you can see on the graph, it shows the huge impact on cost reduction by making cost-efficient decisions. Not only the clinical aspect, CEs also take the initiative from the perspective on hospital management. In Japan, the maintenance of medical equipment is done by the manufacturers on consignment. As shown in the graph on the right, the maintenance costs are a large part of expenditure. Those costs have been reduced by working with contractors. This graph shows the change in the number of CEs duties over the years. As you can see, CEs are taking on more responsibilities year by year. CEs would give suggestions to the hospital director on increase in the number of CEs and improvement in hospital management. Those suggestions are based on the data obtained through the CE's efforts of streamlining operations and reducing the cost according to the policy of the government. CEs work in collaboration with various occupations and understand many clinical needs. On the other hand, even though companies have the technology, it's hard to get real clinical information. CEs become a bridge between industry and medicine by engaging in the development of various products. These devices were developed in collaboration with local companies by the idea of Mr. Jun Yoshioka when he was working at Yamagata University Hospital. They are a charging rack for infusion pump, inspection equipment for foot pump, undressing equipment for shoes cover, oxygen cylinder pressure alarm, waterless infusion pump analyzer. Next, I'd like to talk about my activities. There are mainly 4 things I'd like to share. I'm working at Okayama University Hospital, a leading hospital in the west of the mainland in Japan with 855 beds. We have a wide range of medical and dental departments composed of the department as shown on the slide. Currently, I am a member of the Clinical Engineering Center. The Clinical Engineering Center is staffed by 26 clinical engineers who work in various departments. I work mainly in an emergency ICU under the Advanced Critical Care and Emergency Center. Working in the ICU requires medical knowledge of circulation, respiration, and metabolism, as well as maintenance, operation, and principle of various life support systems. I'd like to introduce some of my responsibilities. In blood purification, we prepare for various treatments such as hemodialysis, plasma exchange, and direct hemoperfusion. And then we assemble and connect circuit to patients. And also monitor patients during the treatment. We suggest the course of treatment based on the understanding of the patient's condition. In respiratory therapy, we assemble the respiratory circuit, perform initial inspections, observe the patient's respiratory condition, and suggest a change to the ventilator settings. We are involved in overall management during ECMO, such as suggesting which cannula or artificial lung is appropriate for the patient, preparing circuits, troubleshooting, and daily observation and evaluation of the patient and the circuit status. Interdisciplinary cooperation is important in order to provide the best possible care to the patient. In our ICU, the patient's condition is shared daily with doctors, nurses, physical therapists, pharmacists, and dietitians, and they work in cooperation with each other. As a result, this kind of collaboration makes each specialty a greater force in team medical care. In addition to my duties as a CE, I am a doctoral student in the School of Medicine, working on my research and solving clinical questions. Recently, we have been conducting research on the mouse brain chest trauma model using hydrogen and the rat ECMO model. We also produce experimental equipment in cooperation with local companies. Previously, in joint research with pharmacists, we studied drug absorption on dialysis membranes and published an article. Research in cooperation with multiple professions help us achieve what we cannot have done alone. In this way, it is possible to create new evidence through research from the viewpoint of a CE. Moreover, clinical engineers play an active role in the event of disaster. Japan is one of the countries most affected by natural disasters. So there is a disaster relief team called DMAP, consisting of trained doctors, nurses, and logisticians, including CEs. And the team operates with mobility in multiple casualty cases and major disaster acute situations. I'm a member of this team, and we routinely conduct training and manage medical equipment. Okayama Prefecture has the fewest rainy days throughout the year and is called the Land of Sunshine. In July 2018, a typhoon made landfall in Japan, causing the first major disaster in Okayama Prefecture. A hospital in Okayama was flooded and many patients were isolated. We were on the scene and transported 35 patients to other hospitals. CE knowledge is also useful in these out-of-hospital activities, such as managing medical equipment, securing power, and establishing communications using satellite phone and the internet. Next, I'm going to talk about the collaborative projects with Myanmar. Okayama University has a long history of medical cooperation with Myanmar. As a clinical engineer, I'm involved in two projects. One is to train emergency doctors, and the other is to educate medical engineers. The project for enhancement of medical education, so-called PEME, is a project to train doctors to become leaders in a new field of emergency medicine in Myanmar. As a clinical engineer, I've been promoting the role of CEs and what we are doing to training during their stay in Japan. In this project, after 3 months of training in Japan, we supported the returned trainees to hold a dissemination seminar for residents and medical students in Myanmar. I performed a hands-on seminar on a ventilator. Next is the project for human resource development of medical engineering, MEP. It's a project to educate medical engineers at the University of Medical Technology in Myanmar. I have given lectures on BLS, anesthesia machine, defibrillator, and ventilator during the past 2 years. A total of 36 Myanmar medical engineers have been established so far. Including Japan, the recognition and treatment of CE are still not satisfactory. We believe that such activities will provide a way to internationally instill more recognition of CE as a profession. Finally, there are reports from various positions on the measures for COVID-19 involving CE. The Japanese government requested Japan Association for Clinical Engineers, JEIS, to cooperate in efforts to prevent the infection of medical equipment in the hospital, to enhance maintenance and team medical initiatives of ventilators and ECMO, and to cooperate in the selection and use of ventilators. At the request of the government, JEIS worked on measures against COVID-19 in cooperation with related societies. JEIS requested its members to cooperate in effort to prevent infection of medical equipment in the hospital, enhancement of maintenance and secure consumable for medical equipment, and report of the number of medical devices used to the administration. JEIS also took the initiatives such as establishment of various guidelines, creation of educational materials, and recruitment of clinical engineers. At the same time, CEs in the central ministries have been working on COVID-19 countermeasures by using their expertise and networks. For example, the Ministry of Economy, Trade and Industry is taking the measures shown in the slide. Furthermore, the Ministry of Health, Labor and Welfare has been taking the measures shown in the slide. At Okayama University Hospital, our Advanced Critical Care and Emergency Center accepts patients with severe respiratory failure who require a ventilator or ECMO. We prepared manuals for medical equipment management to protect medical staff and protect the spread of the virus, such as disinfection methods, isolation period until virus inactivation for each equipment, selection of ventilator type, selection and securing of consumables such as filters, aerosol measures when the ventilator is opened, and so on. We have created a community of CEs throughout Japan and shared the most up-to-date information and our experiences through online seminars. Because individuals rather than organizations work, the speed of information dissemination was very fast, and we were able to make a variety of contributions to the current COVID-19 situation. And also, we held an online seminar to disseminate infection on infectious disease control for medical equipment. There were more than 1,000 participants, and we believe that we were able to meet their needs. Next slide shows graphic about the content of my presentation in one of the online seminars. And it was illustrated by our friend CE, who is good at graphic recording. I think this kind of skill could be an important ability in diversification of CE's skills. So right now, my friend is doing the graphic recording. Would you like to have some copy? I will send it immediately after the seminar. Lastly, I'd like to talk about my vision for the future. Rather than deepening only clinical engineering knowledge, I'd like to make clinical engineers more valuable and contribute to the society with diversified experience and knowledge through a wide range of activities such as disaster response, research, human networking, and international collaboration. Thank you for joining and listening to the seminar. I hope everyone enjoyed and learned a lot of valuable information. Thank you.
Thank you. Thank you, Takahiro, for giving us an insight of the diverse roles of clinical engineers in Japan. I think looking at the chat room, I see quite a few questions there. Okay, I think I see one. What are the measures, Takahiro, what are the measures taken to prevent cross-infections arising from the use of medical equipment? There's a question from Hui Fen from Singapore General Hospital.
長澤さん、じゃあ通訳お願いしていいですか？
これ今、交差感染、医療機器の使用に起因する交差感染を防ぐ対策はどのようにされてますかっていう質問です。
はい、私たちは、基本的には患者さんに使用した後は、必ず、ゾーニングをまず行いますよね。ゾーニングを行って、汚染された機器を隔離することはやっていて、機器それぞれにおいて、COVID-19 の、生存期間が論文で出てましたけども、それに応じた隔離期間を設けて、例えば3日置いたらこの機械を使えるといったマーキングをしました。
すみません、もう一度言ってください。
隔離したいよね。
隔離したいよね。
そうです。隔離したりとか、あとはウイルスが死滅するのを待って使用する。ちゃんとそれが分かるようにしましたと。何日に隔離始めたとかっていうことです。
So basically, after using or before using isolation of the affected equipment were done, and by labeling what day those were isolated, the equipments were waited to see the viruses were dead. 聞こえました?
Okay. Okay. Shall we move to the next question? Do
Yes.
clinical engineers centers in all hospitals in Japan play a similar role like in Okayama University Hospital? From Emily Lim.
これでいいですか？大丈夫ですか？
同じようにやってます。
日本の岡山大学、全大学が岡山大学のように働いているのでしょうかっていう質問です。
はい。病院によって異なることはあるんですけど、大体同じことができるので、病院でやってることに合わせて C はやっています。なんて答えたらいい？そんな感じです。
はい。
So depending on each hospital, there could be some variation, but basically they are doing the same things.
Okay. Thank you. The next question. What is the education process before one becomes a qualified clinical engineer?
大学に行って4年間のコースを学ぶ、もしくは専門学校に行って3年間のコースを履修した後に、私たちは国家資格を受ける資格をもらえます。で、その国家資格をパスすることによって、国家資格の試験をパスして、
3 years カレッジでいいよ。
C がもらえます。C のライセンスがもらえます。
So by going to college for 4 years or attending 3 years of a medical institute, and after passing the national exam is a qualification to get a license.
Okay, maybe I can just add to this question. When you say we go into 4 years, what kind of background will this student be studying? Will it be engineering basically, or medicine? Or if it's engineering, what kind of engineering?
もともとの背景は関係なくて、高校卒業後にその専門の大学に行くとか、専門学校、3年の学校に行くという形になっているので、海外のように、例えば他の電気とかの工学を学んだ人が、その2段目として、クリニカルエンジニアになれるわけじゃなくて、そういうのによっても直接高校卒業後から、学校に入る形になります。お願いします。
So after high school, getting into this specific college that is meant to educate for engineering and medical knowledge to get the license of the CEs.
So the meaning is it's not only the engineer. It's usually in the United States go to the engineer university, and after graduating they become to some clinical engineer or something. But in Japan is they have exactly specific for the clinical engineer course. They are all included for the medical and also the engineer. So we learn to the both sides during the 4 years, and after that we try to get for the national certification from to the Japanese government.
Okay, I think the next question is related to that as well. For the clinical engineers, after graduating and before getting licensed, what type of clinical competencies are required I think, Pekka, can you move up a bit? I cannot see the bottom of the question.
I need to.
Yeah, okay. What type of clinical competencies are required for these clinical engineers? And is there a system in place to ensure that all clinical engineers undergo a uniform process of training?
卒業 CE の場合、卒業後、ライセンスを取得するために、何か臨床で求められるんですかっていう質問ですね。
特にはないですけど、学生、そのエデュケーションプログラムの中に、例えば透析の回路を作るだったりとか、呼吸器の、臨床的な知識に関する教育は受けているので、その中での実習などはあります。ただ、卒業してからは特にそういったのはありません。
So within the educational process, there is already something to do as a clinical training or practice. So after graduating, there isn't really anything because you get the license as after you graduate.
Okay. Maybe I can just add to that question. Is there a time period from after graduating and getting the license? Do you have to get a certain number of years of experience before you can be a licensed or a certified clinical engineers?
No, there's no time range or anything.
Okay. Vika, any
So
other?
after the graduation school, and we have a national certification test.
Okay.
The government certification test.
Okay.
And if someone pass for the test, and they can work as a clinical engineer. And after that, if you know more specific situation, like a perfusion or some other special equipment, they have a on hand, it's each hospital teaching for the whole, it's making to the professional exactly after that.
Okay. I see from the chat room, there's another question here is from Dennis Pang. Do clinical engineers cross support to other hospitals? What type of training do clinical engineers in Japan receive from ME? I suppose you are referring to what, medical equipment vendors? Can you see from the chat room?
CE は他の病院と連携して、どのような研修を、業者さんから受けているかですね。
もし、私たちが新しい機械とかを購入したりとかするときは、業者さんから一定の教育は受けます。その後に関しては、基本的には私たちが、それらの管理を請け負って、例えば現場の教育などは私たちが行います。ただ、重大なトラブルとか起こったときは、また連絡を行って、メーカーとコンタクトを取って対応をします。お願いします。
So if we buy new equipment, we will get a basic training from the vendors, but after that we can start training others. And if there is some kind of a huge trouble or a problem that occurs with the equipment, then we will go talk to vendors again.
Okay. Right. There's one question from Marcella. You are a really big department. How many medical devices do you manage in your hospital? In her experience, it is unusual that a clinical engineer observes patient status and suggests settings of equipment. Is this common in Japan? Shouldn't this be a medical competence?
少々お待ちください。
デバイスの数は、ちょっと正確に、例えばインフュージョンポンプは200とか、100とかかな。それぐらいあったりとか、心臨時ポンプも同様に100以上あります。呼吸器に関しては、30台ぐらいはあります。その他も栄養ポンプだったりとか、様々なものはあって、私たちは基本的に装置を中央管理して、一つの場所に一括で管理を行って、そこからメンテナンスを行った後に払い出すような形をとっています。一つの質問はちょっとこれでお願いします。
So we're not so sure how many exactly, but about infusion pump about 200, syringe pump about 100, respiratory machine was about 30, and we do central controlling, we do maintenance, and then we ship it to each department.
And the second part is very unusual for that as clinical engineer observes patient status and suggests settings of equipment. So is this common?
これに関しては、確かにおっしゃる通り、私たちは医師の指示のもとでしかこのようなことはできないので、私たちがやっているのは提案ですね。患者さんのコンディションを見て、このようにやった方がいいんじゃないだろうかと提案をすることを行います。それに同意されたらドクターの指示で、それらを行っていきます。
So in this case, we do this under the order of a doctor, so we can only suggest or have an opinion to the patient status. So unless the doctor agrees, we can't really do anything. So it's only through an agreement.
Okay. There's one question on the curriculum. Is your curriculum in your clinical engineering program similar to the more common biomedical engineering program in other universities? And the question is it the accredited program by JABI under the Washington Accord? I think first question is that your clinical engineering program that your engineers actually or the students go through, are they the curriculum, are they similar or how different are they from the other biomedical engineering program in other universities, whether in Japan or in other parts of the world? Did you actually have a make comparison? Okay, that's the first part of the question.
質問は臨床工学のプログラム、学生のうちのプログラム、大学とか専門学校とかは、一般的な生物医工学プログラムと似ていますか？ワシントン規定というのがちょっとよくわからないくて、JABET っていうのもちょっとわからないんですが、っていう質問です。すいません。
ちょっとわかりませんね。ベースの人とかいますかね。ベースの方とかで答えてくれる人いたらお願いしたいですけども。
Excuse me. I'm Fumika Aoki, EJS.
Yes, hi, Fumika. Yeah.
長澤さん、いいですか？
どうぞ。
そのアメリカのカリキュラムっていうのがちょっとよくわからないんですけど、
はい。
わかりませんが、日本は国が決めたカリキュラムでどの学校も指導をしています。
そうですね。はい。
Okay.
So we're not so sure how the curriculum in US is, but this curriculum is supported by the state, so it's approved from the state.
Yeah, I think somebody, Hori has sort of posted the contents of what the clinical engineers are doing based on the curriculum, what are they based on. So these are the so-called courses that typical clinical engineers will do during the undergraduate, I believe. Yeah. So it's a 4-year course. Yeah. And I think when we refer to this JABI under the Washington Accord, that means that JABI is the accredited body which actually does accreditation of engineering education, engineering programs in Japan. So the question is whether you know, like say for example, the clinical engineering or biomedical engineering education program in Japan, have they been accredited by JABI?
笠井先生、もし可能でしたら、日本のカリキュラム出していただけるとありがたいです。
Is it? I suppose that one, I think for whether we know whether this program is accredited or not, I think we can check on the JABI website. The JABI website, they will at least show what are the programs accredited by this accreditation body. Yeah, I think there are no more questions posted on this the chat room. I think the time actually we are about 9:44. I think we will move on to our next speaker. Thank you very much, Takahiro, for answering the questions and for your presentation. And let me share the screen. And thanks again, Takahiro, and we will see you later in the panel discussion. Thanks. Okay, we will now go on to our next speaker, Mr. Gary Lim Boon. He's a senior engineer in the biomedical engineering department at the biomedical engineering department at Khoo Teck Puat Hospital, Singapore. The title of Gary's talk is on the current landscape of clinical engineers in Singapore. Okay, Gary, I may take over from here.
Okay, hi everyone, I'm Gary. So currently I'm working as an engineer at Khoo Teck Puat Hospital. So I'll just provide a glimpse of what we are doing now in Singapore as clinical engineers. So pardon me if it's a bit lengthy in words, not so much pictures. Okay, let me just dive right in. What is it? My slides. Okay, first of all, I just want to highlight that, biomedical engineering consists of 3 fields. So the main aim is we need to understand 3 fields, so it's quite wide and deep, and we need to continuously study and upgrade ourselves. And our main role is to close the gaps between engineering and medicine. So for us in Singapore, it's more on the implementation of the medical equipments and the technologies in our own hospital environment setting, which is typically acute care. And then we also have to try to understand what is the relevant industry standards, so as to know what is the best practices, and as well as the ongoing changes that's going on in the world. So the main aim of it is about medical technology management. So the keywords are highlighted, which we want to make it to ensure that the equipment are safe, and the equipment itself is also, the usage of the lifespans is maximized, and then the total cost is minimized to the minimum. So that's the 3 aims for us as clinical engineers in Singapore. So for us, we group them into 3 groups. Generally, they are called diagnostic, therapeutic, and analytical. So diagnostic means is to do monitoring like physiologic parameters, and the therapeutic itself is to do therapies like infusion pumps and defibs. And then the analytical will be the labs. So in Singapore, it's a bit different, is that we are covering a much wider groups of medical equipment instead of just specific types. So let me go right in a bit more to describe our responsibilities and activities. So within the organization, we have to involve spec draftings, where you try to come up with specification on what equipment you need to buy with various stakeholders like doctors, RTs, nurses, and as well as other aspects that is required for the equipment. So, and then we also have to understand what is the current technology trend for each product that we're going to buy, as well as the installations, replacements when this is being called on. Like the equipment has been used for about 5 years or 7 years, or when it's due to be replaced, we also be called in to give our inputs. And just like when you try to buy a new, I always use mobile phones because everyone owns a mobile phones. So be a new time, first time when you buy mobile phones, or when you want to replace an old mobile phones that you have, you go through a series of thinking and thoughts. And then that's where the spec drafting authority comes in. You think about what is the functions, what you need, the price. And then this is very similar to what we are buying equipment, followed by commissioning. You'll be checking the new machine that we buy, as well as for equipment you want to borrow in and to trial the machines to determine does it meet our requirement and needs for the specific use. So after that, you bought the equipment, you have to go into maintenance so as to keep the uptime of the equipment so that it can support operations of the hospitals. And it's an ongoing process where we keep on doing our own assessment and recommendation. When the equipment is due for overhaul, as well as when we need to dispose, meaning that on its useful lifespans or the repair cost is too expensive, then the disposal recommendation. The other key aspects that we also will be very focused is on alerts and recalls, which I'll touch on in the next slide. And furthermore, we also be doing hazard occurrence, meaning when you use the machine, there may be some issues that the user report that is, they may find that some anomalies that the machine is behaving. So we'll be triggered to do our own follow-up, to investigate. So it's like an investigator. And then after that, we do our own recommendation and our findings to the users and see how we can overcome the issues. And we also have to deal with licensing, which like ionizing and non-ionizing radiation. So we will be in charge of the applications and renewal of the license. Okay. And on top of that, we also have to maintain all the records like job sheets, checklists, service report into a unified database. So why is this so important? Because it's just like a birth cert of the equipment. So to every people, when you are born, you're given the birth cert, as well as all the birth records, and then your health histories. So the equipment for each and every individual has its own. And our job is to capture all this information as a trace record and history. So as we can use the data to do some analysis, and then to look on at it, whether there's a need to have some improvement programs, or whether the existing maintenance program is sufficient to ensure that we meet the requirement to keep the equipment high reliability and then low cost in terms of maintenance costs. So we also have our role in civil and pandemic emergency in Singapore, where we have to support national civil and pandemic emergencies, like even the recent COVID, which I'll touch on a bit more later. And we also play a role in providing support during utility failure. So In the hospital, we have water, electricity, gas. These are the major utility infrastructures. In the event there's a disruption, we'll be calling to support, to advise and see how we can manage and mitigate the damages, as well as when the utility are restored, we will help the users to ensure that it is safe to resume operation. And we also have to manage budget, which is operating budget, the cost to maintain the medical equipment. So we are being tasked as one of our main role to keep the cost low, as well as to maximize the cost to ensure that all equipments under our care have its best uptime, and then the repair costs are also being monitored and watched on. And the next point I want is, as well as we'll be playing a role to advise users whenever the equipments are announced, end of service, end of sales, from the manufacturer or even distributor. So we'll be always providing info to the users before the annual budgeting cycle to see how they can plan and put up the budget to replace them before it fails or before there's limited support from the manufacturer. As well as the next thing is accreditation. So in Singapore, we do follow up with JCI International Accreditation. And our role is to ensure that we comply to their standards. And then whenever the audits comes in, we try to improve if there's any findings. Last but not least, we also, I would say, maybe consult advisory to our own internal staff, hospital staff, especially administrators and ITs. We give our valuable inputs with our expertise and our knowledge about this medical equipment. So how about outside organization? For us, we have to comply to government regulations, and as well as we provide advice to medical device manufacturers, even distributors, to provide our inputs if we find there's any product design improvement through our sharings, as we work with users who are using the equipment. So that's where we gain better insights and issues that the users face. So we can redirect all these feedbacks back to them so as to help them to come up with better products. And we also serve a very key role as a bridge between hospitals and distributor or manufacturers. Why? Whenever there's a medical recall, because distributor and manufacturer may not know in detail what's the current context and the environment, how each hospital operates. So with our being a bridge between internal and external customers, so we provide information and valuable insight to see how is the impact of this each organization. And then before we come up with the risk assessments and our recommendation on how to mitigate the risk for every single medical alerts or recalls that has been triggered and informed. So what's the key thing why I emphasize on medical device recall? Because it is a very big headache, because it will result in unsafe or defective products, like the case of Samsung, where there's a mass recall of its mobile phones due to defective batteries. So medical device itself is expectation is to be safe, to be used on patients as well as operators. So it's a different ball game. So the expectation from the public or even the users, even the patient itself is supposed to be a device that treats. Thus, our role is to work with, to build a relationship with the manufacturer, distributor, even the authorized authorities like HSA, our own internal departments, and as well as other hospitals, to work out and link up to see what's the best practices and how to understand the impact, and then to see how we can mitigate this risk. Okay, a bit more info is on the COVID-19. I'll just share on. So for us, during this period, we play an advisory role to the task force, which is our own management for this COVID-19. As we have the full inventory of the medical equipment in the hospital, so we provide an advisory to see how we can meet areas that need to be ramped up due to the conversion of areas to be ICU capable. And at the same time, we still have to manage our own limited resources due to the segregation of team. And constantly, we need to track and then report the operational of key devices like ventilators, bedside monitors to the task force to keep them update how is the resource on the ground for medical equipment to support the COVID patient. And this also brings on the need for us to also track on the spare parts for these critical products. And we also have to prioritize our team to see how the repair to be done for critical equipment during such periods, so as to ensure that attention is given to this equipment first. And at the same time, whenever there's a need of medical equipment to be redeployed to certain areas, we will cease to look at it and redeploy them. So we need to scout, look around, and see how we can redeploy all this to the key areas. And last but not least, we are essential workers. So we do provide direct support to the frontline workers as we need to service the equipment. Yeah. So let me share a bit more in depth on how a typical biomedical engineering department is like. So this is a typical department organization. So you start with the head department, and with admin, engineers as a second tier, and for the groundwork, it will be a team or even 3 teams, depend on the size of the hospital. Okay, so there's a lot of query on how the academic requirement is like. So for management and operation, you need a degree with relevant working experience is preferred for managerial and senior position. For engineers, the entry level will be a diploma, degree in engineering. It can be quite diverse from electrical, electronic, or even biomedical. And also others form of engineering degrees we may consider. As the key G's is understanding about engineering concepts. As in Singapore, still trying to develop how a CE engineer's framework or academic certification. So as for now is for any form of engineering we'll consider. As for the technical side, for the senior position will be, it should be a diploma in engineering, electrical, electronics, and biomedical. And for engineering assistant, the entry level will be the same, as well as we do consider higher NITEC for the position. And okay, the career path. So for management-wise, this is the typical career path: engineer, senior engineer, assistant managers, and the technical side. So it's quite very lean. But along the way, you get to learn a lot of new stuff, especially as the technical side. When you get a degree, you can move on to be an engineer. So the next thing I'll elaborate more is the other requirement. So your academic may give you a head start, but during the years of your career, you need to develop and constantly improve yourself. So you can see there's so much more you need to learn in terms of soft skills. And the role you take on as you go up your career, you need to be very diverse and well-versed. As we are not just dealing with just equipment, as well as we need to do function as different roles. I'll call it that we are middle tier to cover the top and bottom. As well as, because we are being in the service industry, so we need to provide services, and this means that we need to be, we need to think far, and we need to give our inputs and being clear in what we are saying. Yeah. Right. So what are the challenges itself that is facing in the biomedical field in Singapore? It's very different from Japan. There's no proper accreditation program, due to its complex landscape in Singapore. From the slide I showed in the previous few screen, is that it seems to be covering a wide range of equipment. Our roles are also quite wide as you climb up the corporate ladders. And also there's constantly in-depth of integration of IT with medical device. There's telemedicine, as well as robotics. So all this is getting more and more IT staff integrating. Why? Because there's a demand for more accessible, affordable, and community healthcare, and became a pretty challenge for everyone in this being a biomedical in Singapore. The other forces I feel is there's also a rapid innovation, and the product life cycle are getting shorter as there's demand for products to be released in the market due to business need. And then this brings even more challenge to the manufacturers, consumers, regulatory. So, and then this brings up, there's more patches and then issues that we need to address as the part of product life cycles. And one of the most common one that we always hear is cybersecurity. Why? Because we are all in a hyper-connected world. Everyone is on the network. So, and we know it from news, there's also the personal data link at SGH. So this drive at the national level, that cybersecurity is of very importance. And it's also a challenge for us as we need to also brush out our own technical knowledge and on IT. So I would say that it's quite a steep learning curve for new joiners into healthcare as biomedical engineers. And you do not stop, you just have to keep on upgrading, learning, and picking up along the career path. And you just need to keep on pushing and pushing yourself to learn more. Maybe piecemeal, but you try to join the dots and link it up to understand what's the whole picture like, right? So, okay, that's all I have. Thank you. Right.
Yeah, thank you very much, Gary, for giving us this insight on the roles of the engineers in the biomedical engineering departments in the Singapore hospitals. I think there are a couple of questions. There's one, which is for you, Gary. For medical device recall management, is there a national guideline standard in Singapore?
Okay, in Singapore itself, there's some framework from the regulatories, but many times we work with the manufacturer or distributor directly to come out how to manage all these recalls. So it depends on our knowledge and our network with our users internally as well as externally, so as to understand how to mitigate this risk. So I wouldn't say there is a guideline, but we have to comply to regulations. Hope that answers your questions.
Okay. I think there's one question from Jason before you came on. I'm not sure whether it's directing to Takahiro, or anyway, I think both you and Takahiro can answer this. Is there any medical equipment manufacturer to assist the clinical engineer certification? I believe this will be for Takahiro.
臨床工学の資格取得に支援してくれる医療機器メーカーはありますかっていう質問ですね。
臨床ごめんなさい。
臨床工学技師の資格取得を支援してくれる医療機器メーカーはありますかっていう質問です。
それはないですよね。
For Japan, there's none.
Okay, so there's no no option or no way that the medical equipment manufacturer can assist in the certification of clinical engineers, I believe. Correct, Tomo?
Yes, sir.
Okay, thank you. Okay, question here from Keiko Fukuta. Thank you for presenting great presentation. Please let me ask some question in the engineering department. I believe this for Gary. Are there other engineers work with you, such as electrician or only biomedical engineers?
Okay, I would say that for me personally, I will find out and work with my hospital electricians, or even my contacts or friends who are electricians, to find out, so as to know what's their best practices and what's their guideline. Since we are not electricians, but trade itself, so that's where networking comes in. So you have to ask and look for people of other expertise, and then seek their help or input to help you in your decision making or in the day-to-day work, I would say. Yeah, that's how I would say I answer this.
Okay, and okay, another question is from YN. Do you use, okay, I'm trying to see this. Okay, do you use any AI like program, okay, can you move up a bit, Pekha? I can't see, there's a, okay, in your department management, do you use any AI like program in your department management to track devices, alert PM, and use overuse alarm recalls to suggest the decision-making team? Any interesting AI applications in the CE department?
Okay, I mean, for Singapore context, no, we have not started on anything like this, although there's always the interest in big data, we do data mining. Because itself, we need to, I always believe a system is developed by humans, so you need to input valuable data inside. So what you input in is meaningful, and then only can extract it out. So you must have a vision and begin with the end in mind, or what you want the system to do. So you can do a lot, provided you have understanding what you wish to extract from the system. And you can have alarms, recalls, and decision making. I always believe decision making is pretty tricky, because you're dealing with medical equipment. It's not like your own laptops or watch or something that's more simple. We are doing a more complex product itself. So I think it's possible, but still quite a long way. But we do tap on to, products like 2D barcode system, RFID, to help us in our day-to-day work, to track equipment. That's a trend that we are moving on, that we are trying to embrace also. Hope that answers that question.
Okay, yeah, thanks, Gary. There's one question regarding professional certification. Do you think that having a professional certification, such as that in medical and nursing, will help to improve clinical engineers in Singapore, improve the status of clinical engineers in Singapore?
I mean, if strictly speaking, yes, I do believe. But then it comes at the other question is, where's the end point? You know, we know that I mean, academic-wise, you can get yourself, you can study and get yourself better knowledge, but then you need to strike a balance between this and also practical, you know, joining the workforce. Because you keep on doing your academic studies, right? So then how many more years left before you can go into the workforce to contribute back and to learn? So that's also another teething question, I would say. So in the end, I can only say the way out is you can start your career by having some basic academic qualification, after which you need to keep on upgrading yourself. That's why I would say it's a constant lifelong learning. It never ends. As we know, in the world of medical, it's also evolving and changing. So it's a non-stop learning. You just have to keep on upgrading yourself along the way through bits and pieces, or even taking higher learnings to get yourself better and more knowledgeable, and then qualify yourself.
Okay, thanks. I think there's a question from Hui Fen. Is CE certification a requirement by the manufacturer to do corrective and preventive maintenance in Japan? So I'm not sure whether you can take this question, because it's asking a requirement by manufacturer. Gary, what do you think? Did you see the question on the screen?
Okay, I mean, personally, I would say, well, I see in a way that manufacturers are the ones who design and develop the product. So definitely they have in-depth knowledge about the product that they developed. So, but then it's a teething dilemma question, because how much do the manufacturer wish to disclose or share with you to get yourself be certified or trained? It's really depends on their comfort level as well as the trust. Whether for us as CE to be able to qualify and manage the equipment. So it's always a conflict of interest sometimes, I feel. But then some manufacturers believe and that we are a value to them because we can provide first-time support to the front line, to the doctors or even the nurses. It can be even be enrolled to educate, you know, if you are competent. So that's really subjective. That's why even till now it's debatable, you know, how this works, as the various interests at stake, you know, at different parties.
Okay, there's one question from Saravanan Rajendran. He'd like to ask, how different is management and technical BME roles in healthcare clinical engineers? And why different educational paths are needed for each? Okay, degree for the former and diploma for the latter.
Okay, well, generally the path itself, I would say that for the technical side, it's the groundwork. So you'll be dealing with the machines and servicing it. And along the career path itself, even as we reach a manageable role, we still need to be hands-on, as this is our bread and butter, I always believe. So you can be a degree trained and then you step into this new job, but then you still need to work your way up to do hands-on, you know, just like technical guys. As along the way you'll be doing advisory, and then you're giving your feedback during tenders and even doing investigation. So I would say technical itself is more of groundwork, but as you move up the management role, you still need to be capable to do technical as well as to handle more roles in management. So it's more demanding itself, actually, I would say, for management roles. Yeah, hope this explains. The career, I think the academic path is just a guideline for head start, for entry levels. It's a guideline, I would say.
Oh, okay. A question from Eric Wu. Gary, do you think it is helpful for clinical or biomedical engineering groups to start developing a guide to manage the complex integration of medical device and IT?
Currently, we are working with IES, which is the IT company under the MOH holding, to come out with some guides. So it's not easy because by itself, we are not IT trained itself. So, and although it's part of one aspect of engineering itself, but we are pretty not very well versed and know about this. So we are doing something about it and trying to see how we can help each other out by working with ITs to see how we can bridge and make it work for everybody. So, but separately, we ourselves also need to start upgrading ourselves. So it's challenging in itself because IT itself is another school of engineering which is quite wide and it's very deep itself. Yeah.
Okay. There's one question from Nangwin. Please let me know the practice in Singapore for service contract to minimize the system downtime.
System.
You see the question in the chat room.
Okay. I would say service contract itself. Wow. Okay, since it depends on what you want, I would say. Yeah. So to me, I feel service contract is just like an agreement, you establish with your distributor or even contractors. And what is it that you wish to get out of it? You see. So you must know, have an end point. What is it you wish to look at? Is it a cost or is it system uptime? Or is it maintenance? So which aspect you're looking at? So you need to strike a balance and see what's the main aim before you can determine what kind of service contract agreement you wish to take. Yeah. So there's no perfect answers to this. It really boils back down to what you want, before you can determine. So in Singapore, it's the same, there's no one-size-fits-all service contract. It really boils back down to what you wish to get out of this contract agreement with the vendors.
The last question which I want to pose to you at this point is from Ray Yao. What new skill sets do you think BME departments in the universities should train so that engineers can be better equipped for the BME engineer job in hospitals?
I would say skill sets. For my time, when I started biomedical course, it's at the preliminary stage during my degree days. So for me, I would say knowledge on basic human anatomy, the biology, it does help us a lot as far as understanding more on even IT, since it's something that's always a challenge for us. Maybe these two new modules or skill set may help us just at entry levels to help us to kickstart. Maybe that's something for a start, I would say, in the university.
Thanks again, Gary, for giving us an insight on the roles of this BMEs in Singapore. Maybe if you look at the bottom of the screen, reactions, we want to give Gary a big hand, and also Takahiro a big hand on the presentation, a clap, applause, or something like that. Yeah. Okay. Thanks very much. Okay. So can you the two speakers stay on screen? I would like to start on to the next session of this seminar. Okay, well, I've already introduced Takahiro and Gary to you earlier on. So this is the time when we're going to have a panel discussion. The next person I'd like to introduce is Professor James Goh. He is currently the Professor, Department of Biomedical Engineering and Research Professor at the Department of Orthopedic Surgery, National University of Singapore. And he is also President of the International Union of Physical and Engineering Sciences in Medicine. In short, is IUPASM. He is also the immediate past president of the International Federation of Medical and Biological Engineering, IFMBE, and he's president of the Biomedical Engineering Society, Singapore. And we are also very fortunate to have with us Mr. Tom Judd, all the way from the United States. Tom is a certified clinical engineer and certified in healthcare quality and health information management. He was a former national project director at Kaiser Permanente Clinical Engineering. He's currently the chairman of the IFMBE Clinical Engineering Division. He has been the World Health Organization Health Technology Advisor since 1989. Tom, before I ask you to say a few words, let me introduce the moderator for the panel session, Dr. Mark Chong. He is the Senior Lecturer and Program Director of Bioengineering at the Nanyang Technological University, Singapore, and he is the Faculty Fellowship Head in Singapore Biodesign. At this point, may I invite Tom to say a few words before we start with the panel discussion. Over to you, Tom.
Yes, thank you, Sulak. It's great to be here. What a fantastic turnout and what a fantastic set of questions and presentations. I sent out ahead a few things that I'm going to cover extremely quickly. One was a link to our upcoming programs and then some other things. Unfortunately, I sent out earlier the wrong link, and now you have the right link in the chat at the top. But the Global Clinical Engineering Group is putting on 2 programs in the next 10 days I want you to know about. One is on clinical engineering innovation, and the other, besides our work with our friends from WHO and our publishing in the Global Journal, is a WHO Clinical Engineering Division town hall on decontamination and disinfection of COVID equipment, the workers and the patients, really covering all those bases. And let me show you a little bit about that program. There's going to be in an hour and a half here on July 16th, and that'll be, let's see, that program is at 10 a.m. New York time, my time, so to speak. So that'll be 10 at night for, or 11 at night for you folks in Japan or Singapore. But and it'll be taped, YouTube and all that, and so you'll be able to get it afterwards. But the WHO perspective, a standards perspective, a clinician perspective, a LMIC perspective, as well as 2 experts on surfaces, both assets and people, of what happens with decontamination and disinfection, and also airborne. And then a half-hour Q&A as we've done in some of our other programs. So wanted you to know about that. And once again, so number 1, glad to be here. 2, some of these things I've shown you, my colleague, Dr. Yadin David, and I were at the Japan program, the Asian Pacific APC MBE program a month ago at Okayama. It was a virtual meeting out of Yokohama. And we talked about, and I've sent you that program about the Global Clinical Engineering Group's involvement in COVID-19. But what we're about, you know, globally is less important than how we help you locally do whatever you do better. So hopefully all of this is aimed, these 5 town halls that we had with WHO in May were aimed at giving you answers to your questions so that you can advise decision makers in your country. And we also addressed, a couple other colleagues addressed the difference, some of the differences between global credentialing, which is a fancy word for certification and registration, between, you know, the rest of the world and Japan. So a lot of questions about that tonight. We'll find that very interesting. one of the things I showed you very quickly was this webinar on innovation. Well, I also sent you this document that has a lot of YouTube links on it, but it's about, we identified in recent years 10 unique clinical engineering competencies, and they're thrown into this, program I sent you, which I'm not going to go over now because SL is wondering why I'm taking so much time right now. So 10 competencies, and for instance, besides the traditional HTM, see if I can get there. Yes, cost effectiveness, you guys talked about quality and safety, partnering with clinicians, innovation, we're already at number 5. We've done 4 of those programs. Our involvement in digital health, and a lot of the things we talked about, CEIT, talked about big data, we talked about AI, telemedicine, all of that fits into the digital health bucket. Where are clinical engineers involved in regulation, communications with ministers of health, health leaders, or heads of hospitals, policy, legislation, partnering with allied health. So what I think you've seen from the things that we'll talk about tonight is the Global Clinical Engineering Group has grown tremendously. We're involved with 140 countries around the world. We have communications, a lot of tools for that, and we'd like you to join more of that. Some of you are already in there. And we're giving you answers and trying to wrestle with your questions around COVID-19. I'll close, SL, this short intro with Adriana Velasquez, our colleague from WHO, at one of our town halls in the middle of May during the time of a virtual World Health Assembly, when all the ministers of health came online. They couldn't come to Geneva, but 14 presidents or prime ministers said, COVID-19 and medical equipment. And 130 ministers of health said COVID-19 and medical equipment. This is our time in history, and we found our voice, and we need to use it. Back to you, SL.
Thanks, John. Okay, Tom, Mark, I think you can start with this panel discussion. I think I will off my video.
Right. Okay, thanks, Dr.
Yeah.
For everybody who has just joined us, we have online on our panel, we have Hirayama-san, who is from Okayama University. We also have Mr. Gary Dim, who is actually from Teck Puat Hospital. Professor James Khoo, who is from the National University of Singapore. And we've also got Professor Tom Judd, who leads or who chairs the Clinician Engineering Division. Right. So it's a very interesting and very international panel that we have today, and I'm really looking forward to hearing your thoughts and feedback based on your experiences. For all participants, if you have any questions, please do post them on the group chat, and I'll make sure to go through it. And I will try to prepare these for the panel. To kickstart, I'll just want to expand a bit on what Emily was just mentioning on chat group. About what are changes in roles for clinician engineers. I think I'd like to go around the panel to find out what are the trends and changes that you expect for clinical engineers or clinical engineers in your own health systems. And I would actually like to start locally with both. Perhaps we could start with Gary, and then moving on to Prof. Go for comments. So Gary, what do you foresee will be some trends or changes for clinician engineers in Singapore? Gary,
I think the current trend will be more on cybersecurity, in terms of IT itself. Since there's a use of Androids and then a Windows platform, and there's always a lot of all these security flaws that's being thrown out, mass media, even internet, World Wide Web. So there's a lot of concerns and focus on this. But then it's quite challenging for us, since we need to get ourselves update and then beef up. So it's quite a milestone and upskill task for us, I would say that.
Right. Thanks, Gary. Yeah. So indeed, in this very interesting times that we are in, I guess there's so many changes that are just emerging all the time. I'll be moving over to Tom in a while, but before that, Prof. Go, just wondering on your side, hearing what Gary just mentioned, and coming from the Singaporean perspective again, in terms of education, are we kind of trying to bridge that gap in the trends for training?
Thanks, Mark. I think one of the area which was mentioned, I think by Gary as well, in terms of the area of IT. And also one of the questions on AI, I can tell you that over at the National University of Singapore in our BME program, we are mounting a module with that respect. Looking at IT, looking at AI in medical application. So that's coming on for the students to try and give them a head start into this area. And I think one of the big area that Tom has also mentioned is the, that was brought up as well earlier on, this integration issue of how do you look at medical equipment integrating with IT so that the hospital as a whole system understand what's going on as far as medical devices are concerned. The other area in terms of education for our students, for quite a while now, we have internship program, 6 months internship program for our students in the year 3. Some of these students has got interest subsequently to work in hospital. I hope that the hospital will be able to make internship position open to our students to get in. And already that's happening, but I wish more could be done so that our students get exposure early and get excited and get motivated, inspired to go into this area in their career, to get an understanding of what goes on in a biomedical engineering department in the hospital, so that they can be subsequently equipped moving on as to what they need to learn, what they need to acquire in terms of knowledge, and where to get the experiences. Thanks, Mark.
All right, thanks, Prof. Go. Definitely, we need compare notes on that. I guess similarly, over on our side in the NTU and across Singapore as well, we do focus a lot on trying to upskilling and continuing to learn as we move on, like what Gary just mentioned. So yeah, I guess in line with that, we do want to make sure that everybody continues to learn how to learn in the university. Yeah, I guess especially now with very short tech cycles, right? We could be training something in university that becomes obsolete in just 5 years or so. So yeah, I think that's where we want to actually kind of move away from fundamentals training or training a very, very specific kind of platforms or software, which might become obsolete very quickly. So yeah, but it'll be interesting to compare notes to see how we can build on this. I also want to actually bring the conversation over to Hirayama-san because it's very interesting that in Japan has an almost totally different approach to clinical engineering than most of the world. I'm fascinated to find that there's a lot of integration with the allied health professionals, like we like to term them here in Singapore, where you have the roles of the clinician engineers actually extend beyond the BME, but also to actually go into the perfusionist, the hemodialysis techs, and so on. Back to you, Hirayama-san. I know that you've also mentioned there's expanding roles in A&E and emergency medicine and the like. Would you also see more, diversification towards more connected devices, more IT and more cybersecurity in Japan as well?
Nagasa-san, 大丈夫ですか？
はい、大丈夫です。今の質問は、どんどんとパーフュージョンとか、透析とかっていう業務がどんどん増えていきますけど、その他増えていくことってありますか？例えば IT だとか、増やしていくことってありますかっていう質問です。
専門にそのようなことが含まれてくるってことは 考えづらいんですが、まあ、そのようなプロフェッショナルと一緒にコラボレーションして、医療機器管理とかを行っていくことは行ってますよね。
すいません、どう言えばいいですか？
だから僕たちの業務にそれが加わっていくということよりも、そのようなプロフェッショナルと一緒に私たちがコラボレーションすることはあると思います。その AI とかそういった部分に入っていくことは。
はい、了解です。
So within the IT perspective, it's highly unlikely for us to be having that as a specialty. I feel more of a possibility to collaborate with the professions who are in the IT field.
Right. Thank you very much for the comments. And definitely to round this off, none better than Tom to actually provide some global perspectives.
Thank you, Mark. I did come from Kaiser Permanente, and many of you recognize it's one of the health systems in the US with about 14 million patients and a lot of digital health. Now, I use the term digital health for all the CEIT stuff, and I'm going to define it slightly better here in a moment. But that's what WHO calls this whole bucket of things. And what do I mean, the whole bucket? I mean, you know, a lot of these buzzwords we were using earlier, telehealth, cybersecurity, rise of artificial intelligence, big data, data mining. All of that is in the context of digital health. Let me give an example. In the era of COVID-19, you know, telehealth has become such a big thing. And, you know, the HIMSS, the Health Information Management Systems Society, that's now all over the world, I'm sure many of you are part of it, is partnering with the Clinical Engineering Division as we look at telehealth and telemedicine and how it's going to change healthcare delivery post-COVID-19. So, Mark, if I were to answer the question, where's the education going? Where is in hockey, where is the puck going so that you can go to where the puck's going so you can score the goal? Sorry, I don't have a good Singapore or Japanese example, but baseball, of course, that would be Japanese. Anyway, that's where things are going, is in the bucket of digital health. There is, somebody asked earlier, is the AI being applied to clinical engineering? The answer is yes. There's a body of research, and Dr. Go may know more about that than me, on AI in clinical engineering that's going to be published in the Global Clinical Engineering Journal. I mentioned, and I gave an access link to that. So what do we in CED think are probably some of the biggest things besides these competencies, besides COVID-19? It's training young leaders. Let's say you're 3, 5, 7 years into the field, and maybe you've passed some certification exams, but you're wondering what's next in your career. And we think developing leadership skills and applied to all these competencies is where to go. And so that's why we built leadership skill training into this competency training, like the one on innovation coming up Wednesday in a week. Back to you, Mark.
Thanks, Tom. And I'll just pick your mind on that. On the point of digital health, I mean, like you correctly pointed out, there's a huge bucket that pulls everything in. So I mean, coming back to the university or coming back to any training institute for that matter, how should what are these fundamentals that we should be you should be zooming in on that helps us to better appreciate or better understand digital health, and thus be able to deliver this impact as clinical engineers?
Not a small question, and I'm not going to try to give a comprehensive answer. You've heard enough from me already, but we all know medical device data is getting into electronic health records, and then that's driving care. But then you get so that's for one patient, but then you get a population of patients, and then that's the big data thing, and AI, comes into play. So two quick things about that. One I've already said, people think telehealth will change healthcare delivery. It'll be 20% of healthcare delivery after COVID. So imagine that model is going to change things. So, what skill sets do you need to do that? We all know you got to have the right broadband, you got to have the right tools, and you got to have all that. So let me paint a scenario. What if you were trying to take care of the most vulnerable population in your country? And by the way, this is a question India is doing right now, and they're partnering with HIMSS and CED to work on this. And so imagine everybody has a phone of some sort, because that's the way of the world, that maybe has a locator chip in it. And perhaps with that connection between a health system and every patient, what if there was continuous monitoring, patient monitoring around key vital issues, health issues? And so now think about that package and that scenario of all the things you could do in a digital health context. I don't know if I'm answering your question, Mark, but I'm trying to think, where are we going and how can we use these tools? We have, and you have in your country, we have in our country, expert clinical engineers in the digital health field. I'm thinking of Dr. Elliot Sloan. I'm thinking of Dr. Ricardo Silva, originally from Venezuela, then Ecuador, now in the US. But there's many other folks like that around the world that have already put some programs together, and there's others of you that can work on that together. So.
Right. Thanks, Tom. So yeah, I guess it was really an unfair question as well. I suppose there's no magic bullet that we can just take, and then overnight we all become experts in digital health. And I guess this also links very well with what Prof. Go and what Gary mentioned earlier, that there has to be a lot of practicum. There has to be a lot that goes into this kind of experiential learning, and there has got to be a lot more interfacing between the academics and well, the universities and the industry. Right, thank you. And I just unfortunately, while we are kind of running out of time, but I just saw another question on the chat, which is actually addressed to Hirayama-san. And it's in a way, I guess it also connects to how we want to try to understand how to certify and how do we get folks to be recognized as clinician engineers or clinical engineers. So there was a very interesting slide or this topic that was covered in your talk, where you were talking about a Myanmar project in which you were looking at training the locals and providing this new these new insights. So the question really was, how long is this course that was covered in Myanmar? What were covered? And also, are the Myanmar engineers certified after this training? Over to you, Hirayama-san.
それでは長澤さんお願いしますね。問題は分かりました。
問題は分かるね。はい。
まず、コースに関しては1年コースです。ディプロマコースなんで、例えば工学とか電気とかを出たエンジニアや、ナースを出たエンジニア、ナースを出たナースとかですね、そういった人たちにさらに1年追加して学校に入っていただくことでディプロマがもらえます。
So this course is 1-year course, and it's a diploma course. So we're expecting engineers or nurse that got out of their specific course or school.
コースが終わった後は、今は、国家資格がもらえるわけではないんですけども、今現在はミャンマーなんとかカウンセル、ミャンマーアメリカカウンセルというところが、サーティフィケートをあげるようになっています。
So it is not a national certification that is given from Japan, but Myanmar Medical Council is giving the certification to them.
将来的には4年生の大学っていうのを作ろうとしていて、将来的にはやっぱりそういった国家資格というのを目指すとかいう方向はあるんですけども、まだ今は作っている段階です。
So in the future, we are trying to make a 4-year college, right? And we are aiming to make a national certification, but right now we only have this.
So if I could just ask the next difficult question, how do you expect this to impact the healthcare system in Myanmar after this professionalization of the clinical engineers?
今現在、ミャンマーでは、さまざまな機器がさまざまな国から寄付されていたりするんですが、今までの歴史上それを管理する人はいなかったんです。ほとんどの機械が使えずにゴミになっているような環境でした。ここまでちょっと翻訳お願いします。
So right now in Myanmar, there are a lot of medical devices that are being donated from other countries, but because there weren't anyone who could maintain or control, most of them became trash and been disposed.
そして、機器の操作や管理はドクター、ナースが行っていたんですけれども、とてもミャンマーという国、患者さんもたくさん来るし、設備も整っていない環境で、彼らが、マネジメントすることはやはり不十分になっています。
So control maintenance were done by nurse and doctors, but there were a lot of patients that were in the country, so it was actually difficult for them to maintain and control.
そう、ミャンマーエンジニアは、それらを、管理するだけでも、やはり今まで、捨てられていた機械を有効活用したりとか、将来的にはできたら日本みたいに臨床の現場に出て、サジェストできるようなことがあれば、より、ミャンマーの医療に貢献できるのではないかと考えています。
So by having Myanmar engineers, even just by maintaining it, they could efficiently use the devices. And in the future, we will like to have them support the medical field, just like in Japan.
まだまだギャップは大きいので、それが実現できるかどうかはまだ分かりませんが、それが認められる、認知されるっていうのにはかなり重要になってくるんじゃないかと考えます。
So right now we still have a lot of difficulties and some of the walls that we had to break, but we would expect this system to run as a potential future medical improvement.
Thank you. So yeah, it's right. In the past 25 minutes, we had a pretty fascinating, overview of what's happening in clinical engineering across the globe. And just kind of to sum up some of the interesting points that were picked up. I guess we do see a kind of an emergence of the need for clinical engineers to kind of step up to take up different roles. And in Japan, while there's a bit more overlap with the allied health professionals, in Singapore and in US as well, and possibly globally, we're also seeing a lot more interest in digital health, how the clinical engineers can actually step up to take bigger roles in that. I think that's about all the time that we have, but Tom has actually very kindly also suggested that he can address questions on chat again tonight if desired from the rest of the participants. And as well as if there are any further questions, these could come in a written form as well. I was actually really hoping to engage Tom on your perspectives on the health tech assessments as well, and how clinical engineers might be able to play bigger roles on the reimbursement front. Yeah, unfortunately, I think that's about all the time that I'm given. So I actually have to give the time back to Prof. To. Prof. To, over to you.
Okay, thanks, Mark. Yeah. Okay, first I would like to thank all the panelists and our moderator, Mark Chong, for a wonderful and interesting discussion. All right. Okay, now I would like to invite Professor James Goh, who is the president of BES and chair of the IES BETC, to give his closing remarks at this stage. James, over to you.
So I hope that as a society and also we would continue to use this platform to communicate and bring forth, ideas, interesting topics to you in the future.